Hello and welcome once again to AARC's Big Ideas Theater. I'm your host, Ed Hyland, and I'm joined now by Dr. Gary Newman, who is going to talk to us about a popular and a little controversial subject, novel ventilation strategies to reduce the incidence of ARDS. Dr. Newman, thank you. Dr. Newman, thank you so much for coming by.
You're welcome. Thank you.
Let's talk a little bit right from the top about what does ARDS make, or why does ARDS make the lungs so vulnerable to a secondary ventilator-induced injury?
Well, the classic pathology associated with ARDS is that of heterogeneous collapse. The lung is usually ventilated homogeneously, all the alveoli are inflated, they all share alveolar walls, so the term is alveolar interdependence. So the lung is structurally sound as long as it's totally inflated. In ARDS, due to surfactant deactivation and edema accumulation, we have a heterogeneous ventilation. So now we have normal tissue, we have alveoli that are unstable and collapse and expand with each breath, and we have alveoli that are filled with edema. Now when we try to ventilate that heterogeneous lung with one breath, it becomes difficult. If we put in a big breath, it can overdistend the normal lung. If we put in a small breath, then we can't, a small tidal valve, we may not be able to ventilate adequately. So it's this changing from homogeneous ventilation to heterogeneous ventilation is sort of the key component in ARDS pathology that sets the lung up for a secondary ventilator-induced lung injury.
What is your opinion on the current standard of care protective ventilation strategies for acute lung injury and ARDS?
The current strategy is a low tidal volume ventilation strategy, and keep low tidal volume being tidal volume of 6 cc's per kilogram or less, and appropriate PEEP and FiO2 using the ARDS networks scale. So that is the standard of care. The one problem with that is that it doesn't really address the main pathological problem of the lung. Since we're backing off on the volumes, we tend to exacerbate that heterogeneity. And unfortunately, in 2000, in New England Journal of Medicine paper, there was a 22% reduction in mortality going from a 12 cc per kilogram tidal volume to 6. 31% for the treated group and 39% for the control group. And unfortunately, all of the recent meta-analysis and analysis of ARDS mortality, we're actually still up around 40%. And this would essentially 40% is the same as the high group or the non-experimental group. Therefore, it appears from our own data that we're going backwards. Rather than improving mortality, it seems that the low tidal volume strategy has increased mortality to around 40% rather than the 31% from the in that ARDS study in 2000.
Do you have a better option?
We think we do. Again, I'm a pulmonary physiologist, and we've been studying in great detail the function of the lung at the alveolar level. And we found that alveoli open and collapse with in a viscoelastic system. And what that essentially means is that when you apply a force, in our case in ventilation, a tidal volume, there is a distinct time lag from the time the force is applied till when the alveoli open, and vice versa when you take the force away or you exhale when the alveolus starts to collapse. So what we believe, we should use time-controlled ventilation strategies. We should increase the inspiratory duration, and this will take into account that viscoelastic opening, so that the longer the pressure is held, the more alveoli will recruit with each breath, and then use a very short expiratory duration in order to prevent the alveoli from collapsing. Essentially, the duration of expiration will be so short, the alveoli won't have time to collapse. So the sort of the novel component of this strategy is whereas the standard ventilation strategies use pressure, times, and flows, we use all of those things but add the component of time with an extended duration at inspiration and a very minimal duration at expiration. And we think that will play into the pathophysiology of the alveolus, and it will ultimately open and stabilize the lungs so we have homogeneous ventilation. A better strategy than that would be to apply this same kind of protection early and block the progressive acute lung injury so the patients never even develop ARDS.
Let's talk a little bit about what are the components of mechanical breath necessary to minimize VILI,
Right.
and also to protect the lung.
Again, we think any breath that will either open and stabilize if the lung is already sick, or will never let the lung collapse if the patient is at high risk of developing acute lung injury, will be effective. And again, with our and other groups showing that alveoli are viscoelastic, I think we really have to add the component of time. So it isn't just pressure and flow and volume, but also the time that they're applied during inspiration and the time that they're applied during expiration. I think this takes into account our new understanding of the dynamic change of the alveolus with each breath.
So some of these concepts you're discussing are not universally accepted. Is it something that is worthy of a good, healthy discussion to decide which direction we should go?
Oh, absolutely. And we encourage discussion because all science is based on criticism and critique and constructive criticisms of each other's work. So our group is only interested in improving patient care. That's really the bottom line. So we welcome any criticism of both our basic science work and our clinical work using this time control concept. And hopefully, as a group, we'll come up with the optimal way to protect the patient's lung.
I'm sure you'll draw a lot of interesting comments as well as some great discussions along the way. Dr. Niemann, thank you so much for joining us.
Thank you.
And this is the Big Ideas Theater at AARC, sponsored by Draeger.